we're one of the most expensive healthcare in the world, but yet we're not getting the bang for our buck. And a lot of that is related to culture, and a lot of that is related to how we're offering healthcare. Right now, our healthcare in the United States is being ran very similar to the way the government's being ran. It's reactive. It is, the 23rd hour trying to do things. And we're doing that in medicine. People are coming in, they're getting the best care they can get, but they already have their disease. They already have all the issues ongoing, and they're getting kind of as my dad would say, a lick and a promise, and, come back and see us in 3 months without a lot of direction because there's not time. People are skipping appointments because they have to decide, or am I going to work and put food on the table, or am I going to go to the doctor? And so they're making these real life decisions. And so it boils down to access issues and culture issues.
Hello, I'm Jesse Garza with Premier Leadership Podcast. This is the place where we have real conversations with real leaders. And today I'm excited to have as my guest, Dr. BarryJarnagin. He's the founder of Pneumahealth Ministries. So Barry, welcome, and thank you for joining me today. How are you?
I'm good. And thank you so much for having me.
Great. Appreciate it. I look forward to talking about the things that you're doing within the community-based health space and with Pneumahealth Ministries particularly. But first, would you mind sharing a little bit about your story and what led you on this path?
Yeah. So brief history, very brief, but I grew up in the state of Tennessee. I did my medical school at UT in Memphis. Then I went into the Navy, did all my training in the Navy. But I came from rural West Tennessee, so I have rural background. And I talked to my parents a lot as I was going through medical school and specialty training about how medical care was done back before 1965, which is when the great Lyndon Baines Johnson Great Society, Medicare and Medicaid was formed. Anyway, I did my specialty training. I'm actually doubly boarded in OB-GYN and urogynecology. When I did my training, after I finished, I stayed on faculty at Naval Hospital Bethesda for a couple of years. And then when I got out, I went to the University of Tennessee and was the head of women's services at UT at a family practice program in Jackson, Tennessee. Again, full setting, 19 rural counties fed into that hospital. So when I got there, it was a very typical patient population, poor prenatal care, high risk obstetrics, advanced disease GYN. And what I did is organize all 19 health departments that were in the surrounding area that fed into the hospital. And I got them all in a room and I said, look, we got to fix this. And I said, are you willing to do prenatal care? And they said, yes, of course, we would be happy to assist and do prenatal care and primary GYN, but we never felt like we got any backup. And I go, okay, well, we'll now back you up. I'll back you up. And so I established a high-risk clinic at the university and advanced GYN, which was part of my specialty in urogynecology and minimally invasive surgery. And we organized this, and we had midwives, and we had home health service and the whole 9 yards to integrate these nurse practitioners that were out in rural America that were coming in. And in the course of 2 to 3 years, we revolutionized healthcare to the point where our morbidity and mortality was equal to or less than the private sector in the community. It was an amazing turnaround. Women were coming in, they were getting the prenatal care, and they were coming in when they needed to come in. And GYN, we were picking up disease faster and therefore being able to take care of it a lot faster. So what we learned is that people will go locally when they wouldn't necessarily drive in. And we also found that if that provider, that trusted provider out in rural America said, you got a problem, they'd figure out a way of getting in. This has now been kind of established in studies since then, where rural access to healthcare has been problematic, particularly out in rural America. Morbidity and mortality is 40% higher in rural America than it is suburban area. That gap has grown steadily over the years, and a lot of that's related to hospital closures, physician shortages, not willing to go out to rural America, healthcare deserts, essentially. And it's impacted rural medicine far more than suburban urban medicine. And it's pretty natural if you think about it. You know, if I am coming out of training and I have a family and my family wants to be where there's amenities, where there's things going on, where my wife may be able to get a job, et cetera, et cetera. I'm going to go to suburban urban. I'm not going to necessarily go out into the middle of nowhere, if you will, to set up practice in medicine. It's somewhat isolated. And so there's lots of reasons for that. But the other thing is there's also a study that was done. My dad was a barber, so I'm kind of special to barbers, but there was a very well done randomized controlled trial study done in Los Angeles in black barbershop. And basically one guy would come in and the barber would direct him over to the corner where there was a healthcare provider. The next guy that came in, he wouldn't dissuade him, he wouldn't push him that way. He didn't say anything one way or the other. And what they found is that in the intervention group over the control group being the people that he didn't say one way or the other, the intervention group being the ones he directed over there was a 30/15 systolic diastolic blood pressure change to the better in the intervention group. And again, it gets back to local relational care that is given by trusted people. People trust their barber. So he was willing to go talk to the healthcare person. The nurse practitioner that was out in rural America, they would go to her, and if she directed them in for a problem, they would come. I mean, it's kind of one of those over and over kind of thing. Local relational care is what makes a difference. And so, with all that being said, and talking to my parents about how life was before 65, and it was very much in a very similar mindset of local, relational, people took care of people, community took care of community. If we lived in a community and you got sick, those of us in the community would come and help you, et cetera, et cetera. And that was the way life was done back then. And the doctor kind of traveled around. And so I put all that together, and in the setting of the growing healthcare crisis that has been ongoing now for multi years, is how do we solve it? And there's been a lot of spitballs thrown against the wall, if you will, and a lot of money thrown. And I'm sure you may have seen the studies where we're one of the most expensive healthcare in the world, but yet we're not getting the bang for our buck. And a lot of that is related to culture, and a lot of that is related to how we're offering healthcare. Right now, our healthcare in the United States is being ran very similar to the way the government's being ran. It's a reactive. It is, the 23rd hour trying to do things. And we're doing that in medicine. People are coming in, they're getting the best care they can get, but they already have their disease, they already have all the issues ongoing, and they're getting kind of as my dad would say, a lick and a promise, and, come back and see us in 3 months without a lot of direction because there's not time. People are skipping appointments because they have to decide, or am I going to work and put food on the table, or am I going to go to the doctor? And so they're making these real life decisions. And so it boils down to access issues and culture issues. And so I put all that together and I said, let's change the paradigm. Let's don't have people come to a brick and mortar that may be 30 minutes to an hour away. Let's take healthcare back out to those people. And so I devised a paradigm where mid-level providers, practitioners, physician assistants, boots on the ground out into the community with physician backup to have boots on the ground. And we're doing this through church organizations, churches, synagogues, mosques, out in the community where people trust their local world, if you will. Put a community person, healthcare provider in that space to change the culture of the community. So see patients, but actually have conversations with them, actually build relationships with them, actually give them steps to get better and build a culture around it so that community is helping community. So it's been shown over and over. If I decide I'm going to start a walking program by myself, and then sometimes it works, sometimes it doesn't. But if I have a buddy, all of a sudden we're kind of keeping each other accountable, and the chance of success is much higher.
Yeah.
And so if we build a community of health, chances are there's a lot better chance of making it work. And so we're building healthcare through the communities of churches out in rural America. And then I was going to say lastly, but maybe not lastly, but everybody understands that there is a mental health crisis in this country. And there's lots of, the whys and hows, and we don't have time to get into all that. But piping mental health counseling and assistance through telehealth. We're not going to be able to get counselors out to rural America. But one of the great things about our technology is, mental health counseling can be taken out to there through telehealth medicine. And so we have boots on the ground, telehealth support. Cause of that combination, I think that's the best chance, best opportunity for success. And quite frankly, it will lower healthcare overall in this country if we can build this extensively and be successful, particularly, within each state as potentially we might be able to build and grow. Because I've got a slide on this, but it's kind of like the restaurant business where you have, you're pulling up TripAdvisor and you see a place down here and there's a $1 sign. You see a restaurant down here and there's $4 signs down here. Well, say the longer you keep people in primary care in the healthy side of it, in the $1 sign, and away from the ERs, the ORs, hospitalization, et cetera, away from the $4 signs, you're going to have cost savings. So even though there's a cost to taking those people out there, there's a cost to the mental health telehealth in. Those costs are going to be more than outweighed by reducing the need for ER visits, which are now a lot of times being used for primary care because they don't have anywhere else to go, or they get scared and don't know. Again, getting back to education, they go to the OR quicker. I'm not going to ever say that you would never need a knee replacement, but if I can slow down your progression 3, 4, 5 years, I've just saved global healthcare dollars by a tremendous amount. And that's one person make that multitude, right? And so that's kind of the premise behind it all. And it's been rewarding in being able to build this out. And obviously I'm on the healthcare side and understand the primary care implications and that sort of thing. And I'm now got a colleague of mine who's on the business side who's been instrumental in building out the business model, et cetera, et cetera. And so that's kind of where we are right now. And everybody that we've talked to, healthcare executives, hired very successful people, all love the idea and all feel like it's going to make a huge impact in solving the healthcare crisis. However, the problem we're at right now is, and I tell people all the time, it's kind of like when I was first starting to learn how to operate. Everybody wanted me to be a great surgeon, but nobody wanted to do the first case with me. And there's a lot of foundations and a lot in the states interested. There's a lot of people interested in the program, but we're needing money to get the funding for the pilot project, proof of concept. And then once we get that, there are people who are like, yeah, we want to contribute, but we don't want to contribute until we get that pilot project. And so right now we're looking at how do we get, where do we go to get that money, that funding for that pilot project? Because this is we're nonprofit and it's a love of trying to help take care of people. There's no financial, if you invest, I can't give you money back on your dollar, right? It's very philanthropic. But our website is up. It's Pneumahealthministries.org. And there's a place on there that, people can contribute. But we're looking for, we're currently in the process, and I have a meeting tomorrow. We had a meeting last week. We're meeting with people to try to crack that nut on how to get that funding. And so that's where we are. But we have the pieces in place. We have the technology in place. We have the personnel, kind of the farm system, if you will, for being able to get those people. And so once we get that funding, we can rapidly deploy. And we've talked to multiple churches out in rural America, and everybody wants to be the pilot project, right? Everybody wants to do it. So we haven't had anybody not want to be a part of this. So it's now a matter of being able to get that funding, get that pilot off the ground, and then begin to grow, because it will work. It worked on the women's health side when I was at UT. It's worked. The relational healthcare it works. It just works. I've seen it in my own career and that sort of thing. And so it's just a matter of proving it and then replicating it.
Pretty interesting stuff you're touching on there. Do you have? I'm curious. Do you have a brick and mortar physical location that you operate out of, or is it strictly like travel personnel who go out
So
there?
it is designed to partner with churches out in rural America. Quite frankly, we would do urban too. I mean, there's some urban healthcare deserts as well. The focus has been on rural health because there's so many rural deserts out there. And no matter what state you live in, there are hospital closures happening every year. And every time a hospital in rural America closes, that diminishes the health care in that community by multifold. And so that's kind of been where the focus has been. So we partner with a church in rural America, and so we will go in and we'll actually do clinics and things within that church building, and again try to build the community of the church into being better educated in healthcare. Right now, healthcare literacy rate in the United States, it doesn't pick a state, it doesn't matter what state, 10%. So there's a 10% literacy in healthcare right now. Well, that's a large part of where the problem is. I mean, if if you don't know what you don't know how to prevent a progression of whatever problem you're experiencing. And so getting the word out and getting that education is primo. The 11 most expensive healthcare problems in the United States, the 11 most expensive problems in the United States, all can be modified in a favorable way by modifying behavior.
100%. Yeah.
It's amazing. It's amazing. And so it's about getting out there, seeing people where they need to be, and then giving them, if I tell you, if you come in to me and I tell you you need to get from here to here, but I don't give you the steps to get from here to here, you walk out just as lost as when you walked in. But if we have stepping stones of getting from here to here, then all of a sudden you're going to buy in, because it's no longer not feasible to reach. You're going to be able to, so you see the steps, you see how to do it, and you see how to make it work. And then you have a community that's all in the same boat, if you will, and all growing together from a healthcare point of view.
Yeah. I definitely saw, the whole, preventive versus reactive. I saw that in my career in Navy medicine and a brief time
Yeah.
in civilian healthcare. And I've had numerous conversations with healthcare providers, through these podcasts, and they all agree that like it's cheaper and less expensive and impactful financially to handle things before they get to the point of urgent care and ER.
Yeah. That, that's right. And we're never going to prevent those needs, right? We're always going to need an urgent care. We're always going to need an ER. We're always going to need, but if we reduce that by 50%, number one, healthcare is going to be better. People are going to be better because they're healthier. But number two, they're going to use those facilities less. And so the overall healthcare costs are going to go down, which again is a burden on our society right now.
Yeah.
And so this is, again, it's a huge paradigm shift, which is, but it's kind of, the definition of insanity is doing the same thing over and over and expecting a different result. I mean, that's kind of what we've been doing since 1965, right? I mean, so we got to change the paradigm. And what I'm describing is kind of pulling from the concierge medicine side of the world, which a lot of people are gravitating to who have the financial means to do that, right? Because they recognize it's better healthcare and they are healthier because of it. And so a lot of people are gravitating to that. And so it's pulling some of those principles from that concierge medicine, relational care, spending more time, trying to educate the patient to do better for themselves, which ultimately is better for health.
Yeah, it's a lot of outside the box thinking. And I think, yeah, if you could find a way to crack the code on bringing that concierge concept to the masses, the middle class, even lower
Yeah.
socioeconomic class, all the better for society
I,
in general.
we're there. We're there. I just like I said, we're right now at the funding to get the pilot, and then once that happens, then I think there's no reason why, because we're going to be able to show it. I mean, the technology that we have for the EMR, et cetera, is going to build the metrics, and we're going to have the metrics to look at, and it's going to take. I mean, every study, it takes 6 months to a year to see a significant definable change in blood pressures and diabetes, et cetera, et cetera. And so it's going to be a 6 to 12 month pilot. But once that data comes in, and we have the technology to get all that data, then the world opens, if you will, and people will see and recognize that this is going to be good for people, good for healthcare, and also, again, globally reduce costs by keeping people out of the more expensive areas.
Yeah,
So that's kind of where we are. And again, there's no reason why it will not work. I did it before, sort of. The barbershop study and the other studies have kind of backed me up on it. So it's just more a matter of getting that funding and improving it, and then at that point taking off.
great, great. What have been your major challenge as you try to build and scale this out?
Well, the first challenge I think is I'd never done this before. And I have since retired from clinical medicine to spend my time on getting this going. But I was trying to do all the paperwork for a nonprofit, build all the intricacies of that. If you have a different paradigm that nobody completely understands but what goes on in your brain, then trying to get that relayed to the point where you can get people involved to assist and help. So that was kind of the first challenge. And so, it was a lot of conversation and a lot of reflection and a lot of, every conversation I've had with business leaders and or others I've learned something, I've taken from it, and then I've tried to move forward. And so again, getting the website built was big. I mean, as somebody who's not technically brilliant, getting that built was, a big step. Getting the business plan built was a big step. And, I'm very thankful for my colleague that's working with me on getting that business plan built, because that's in his world, not mine. I've been a part of some of that, but I've never actually sat down and done it. And he did it, and it's marvelous. And the people that helped us with the website, very, very good. I'm very thankful for those people. And so getting up and all the paperwork that's required to be a PC. I mean, so getting all that behind us, that was the first challenge. And then the second challenge is, building the farm system, right? Getting the people who will be the boots on the ground, getting that avenue built to be ready, getting the people, getting the technology, getting all that done. And so that was kind of the second challenge. And now the third challenge is getting the funding. And that's the nut to crack now. But you know, in the scheme of things, I read a lot, and I read on, businesses that, are just now beginning to get off the ground and they got established, 10 years ago. So, I applied for and got the 501(c) about 3 years ago. So, to have done that while I was in the middle of still having a day job and then being able to get all that accomplished. I mean, it's been some challenges for sure, but we got it done, and I'm very thankful that I went ahead and retired and now can focus in on this, because there's people who want to meet, and I would go 2, 3, 4 weeks before I could, and now I can. My schedule's obviously a lot more flexible, so I can meet with people at their time, which is obviously very important. So we're moving forward. I'm a surgeon by training and background and mindset. So I want to do everything today. And so the other challenge is patience and building the relationships, building the networking, and finding that right combination of being able to get the funding and get off the ground. In my mind, it should have been done yesterday, but learning a little patience is probably a good thing for me.
How do you see yourself attacking and overcoming that last final challenge that it sounds like you have with the funding?
Yeah, it's well, I'm hoping that people will just chime in and hit the donate button on the website after this. But we have several meetings lined up, and we're looking at both private and public funding. And we're going to continue to walk the walk and talk the talk, and see if what produces, right? Is it going to be the public side? Is it going to be the private side, or maybe a combination of the two? We're open to whatever, and quite frankly, it's truly been a God thing. I mean, it's truly been a God thing. It's this whole concept kind of came about, and it just kind of would not leave my brain until I got it off the ground. And then all of a sudden I felt better once I started getting it off the ground. The colleague that's been so instrumental, the people with the website, all kind of came into my life either for the first time or as a colleague who did the business plan. He and I coached baseball together when our kids were young 20 years ago, and it kind of not reconnected, and then reconnected in a magical moment that was kind of out of the blue. And it was kind of one of those, why would he and I be at the same place at the same time and run into each other and then strike a conversation, and then here we go, right? It's truly been a God thing. And there's been God sightings throughout this journey. And I'm confident that, somewhere, some way, God will bring this forward, and we'll be able to move forward. And whether it's public, private, or, it comes out, some combination. I don't know, but we're going to keep doing what we can do and trust that we'll get it and we'll move forward.
Great. Yeah, I had a couple of months ago, I had another conversation with a nonprofit founder, and she said that you really have, there's a lot of blood, sweat, and tears on the path, and you have to really keep your why in front of you. So it sounds like you've got
Yeah.
a good handle on that.
Yeah,
Mm.
yeah, I that absolutely is the case. And you do kind of step back and you kind of go, there are times when it's like, all right, is this too big for me? Am I being unrealistic? Is this a pipe dream? But to your point, you go back to the why, and people are hurting, and people are in need, and people need help. And I was a very reluctant person going into medicine. I didn't want to be a doctor. I had no interest in being a doctor. Again, we probably don't have time for me to walk through that journey, but it was a God thing, right? And I'm like, okay, well, why would God want me to be in medicine? And the only thing I could come up with is that he wanted me to be a difference maker in people's lives. So I spent my career trying to be a difference maker in people's lives. Because that's what I felt like I was put on this earth for. Because I really didn't want to do this. I wanted to be a basketball coach and a high school chemistry teacher. That was my goal in life.
Wow.
And again, there's a journey that has some comedy in it. Anybody who doesn't think God has a sense of humor, there's some comedy in it. There's some back and forth, but I figured if he wanted me to do what I do, then I must be a difference maker. And that's been kind of my why of being in medicine. And so all this is that still belief system that God wants me to be a difference maker. And there are so many people out there that are hurting, that need help, that deserve help, who are not getting help by no fault of their own. And we got to find a way to do that. And again, this paradigm shift solves all the problems of being able to do that. The obstacles that it takes to do that, this takes care of it. So I'm going to keep trucking. And I know there are people who keep pushing me to keep trucking. And those are good people. Um, and so we'll keep trucking until we cross the finish line.
Love that. Love that. I'm sure your story, your origin story is quite impressive and interesting. And I know that like when sometimes when we hear the call, we definitely have to answer. Like we have no choice sometimes.
Yeah, yeah. Even if you fight it, you end up answering it.
Absolutely.
But I will say, God blessed me in that I did what He wanted me to do. But I've been able to coach. I didn't coach high school, but I coached AAU.
Right.
And now in my later years, I'm now back coaching in middle school. I I've been blessed in that I was able to actually do what I wanted to do, and I was been able to teach because I was in academic medicine for the large part of my life. And so I've been able to teach, I've been able to coach, which is what I wanted to do while I was doing what I feel like God wanted me to do.
Very nice. Well, speaking about leadership, which that's really involved in the things that you're doing, what are the guiding principles that, kind of guide you as you do, you lead your teams, you coach your teams?
Yeah, I think the biggest thing, the one thing that I think helped me through my career, and I started a lot of programs in my career, and I think the thing that, as I reflect back on it, I was able to keep the noise and the distractions out of the way and stay focused on what my goal was. And I think that's been the key to in trying to implement that in those who you are trying to lead, right? Because there's so many things that can get in the way, right? You're wanting to do X, Y, or Z, and there's so many other things out here that kind of come in and kind of start nipping at the heels, but really don't mean anything in the scheme of things, right? And so it's a matter of just kind of not getting distracted and going down a rabbit hole and not going off the path and keeping your vision on the path forward of your goals that you've set. And I think that's been the biggest thing. And then keeping your colleagues on that path because it's too easy to take a side road. So much noise out. And, I think the businesses and the programs and things that have trouble is when they get distracted from who they are and what their goals are, and they kind of start hearing the noise and kind of going off to the rabbit holes on the side. And I think that's probably the biggest thing. And then, I think, and I don't know if this is where the podcast is supposed to go or not, but I really think, keeping God centered in your goals and I think those are, you got to have God centered goals. And if you have God centered goals and you keep your eyes on that and you keep the distractions away, then, that's a huge thing on getting forward. And then obviously from a leadership point of view, you gotta get buy-in from those who are serving, right? That are under you or colleagues of you or whatever. I mean, you got to get that buy-in. It doesn't matter. You may be clear cut, but if they don't know if they don't know and they don't have buy-in, then that's going to be a problem. So you got to get that buy-in from those people. Obviously, it's good to hire the right people, but sometimes you're put in leadership roles where you don't have. When I was head of the outpatient clinic in the Navy, I didn't have any control over hiring and firing. So it was, you had to get buy-in from those that other people had hired, right? And so sometimes you have control over hiring people. Sometimes you're put in leadership roles where you don't have any control over who's there. And so it's your job to kind of build that team, if you will. And, part of, I'm a huge John Wooden fan. I don't know if I'm probably showing my age here, but
UCLA.
yeah. So he wrote several books in his retirement, and I've read them all. And I the whole team building thing is a huge thing, and I think that's really kind of the key is building a team. You don't want one star player. Um, you want a team that works together. 5 kids on a basketball floor are gonna win or at least be competitive in most every game they play, particularly if the other team doesn't have 5 kids playing together. And if you have 10 kids playing together, you have your bench behind and everybody's bought in to whatever you're doing, you're going to be pretty darn good. And the same is true in businesses, and in academic centers and anything else. I mean, if you have your whole team buying into what you're doing, then you're going to be a lot stronger.
Yeah, I'd say virtually unstoppable, probably.
Yeah, yeah,
One of the great lessons I think we all learned in the Navy is, yeah, sometimes you have to work with what you're given, and you have to meet people where they're at because not
that's
we
right.
expect everybody to be up here, and they're not all gonna be.
Yeah. But again, without beating a dead horse and getting back to Pneuma Health and the principles behind it. I mean, in the same manner, though, you have those. You're absolutely right. People are not in the same place, but when you go and you have an individual conversation with everybody in the team, and you show them that you care, and B, you want to help, all of a sudden, you got some buy-in on what you're wanting to do, and now you can help them where they are. I mean, it ends up being really communication and getting that and meeting them where they are and finding out where they are so that you can help them help you and so you both help each other along the way.
Absolutely, absolutely, that's gold. Switching gears a little bit, how do you see AI impacting the work that you're doing? Do you have any concerns, or are you excited about anything that's out there?
So yes and no. I think AI can be very helpful. How it's going to fit in at this point, I think everybody's trying to figure that out. But I think it can certainly help out in some of the prelim stuff and some algorithms and being able to help those providers help people. Cybersecurity is always a big concern. The more AI that is out there, the more cybersecurity issues I think are going to happen. And then there's some very troubling things coming out of some recent studies that I just read. This was the study was done in GI, and it was AI driven, looking at pictures from colonoscopies versus GI people not using AI and looking at it. And what they found was a bit startling in that the people who were using AI were being were less able to be able to identify things on their own.
Oh,
So the risk of AI is a bit dumbing down population in general, and in the medical world, no different. Being able to, critical thinking is a vital part of good medicine. I would tell patients all the time, it's not a car with a bad muffler. You can't go in, get the old bad muffler taken off, a new muffler put on, and you drive off and everything's fine. The body doesn't work that way. Um, Everything's connected, everything's affected, and critical thinking is vitally important in trying to help that person. So in the midst of the growth of AI and all the value that AI can offer, we've got to be able to continue growing critical thinking within our healthcare community and our healthcare providers and the community as a whole, I think.
wow, that's a very important point I think you're making. Was not aware, like I had not heard that study or that, case study.
It's pretty recent. It just came out within probably since we set this up. I read about it. Now I don't know exactly when it happened, but it's been pretty recent.
Wow, but that's, yeah, that part of my mission with the work that I'm doing is, yeah, to get the word about, like, we cannot eliminate the human aspect. Yeah, AI should be a tool that we use to amplify what we're doing and to give us leverage, but yeah, it could never replace the human aspect. If we think it's going to, we're in trouble.
Yeah, and I think you're right. And I think a lot of the new startups and they're jazzy because they use a lot of technology and AI in treating patients, but without the human factor of the connection, right? Again, it gets back to relational care. It gets back to if you're seeing somebody, you want that person to care, right? You
Absolutely.
want them to care and understand you. You know, a computer's not going to care and understand you. I mean, so we need AI. I think AI is a great tool, but it's a tool in the toolbox that we need to utilize as a tool in the toolbox and not depend on it.
Absolutely. Yeah. And of course, in the medical community, there's always going to be HIPAA compliance concerns as well that we have
Yeah. Oh yeah.
to factor
Yeah.
in.
Yep.
Oh, great. Very interesting stuff. Looking ahead a little bit, what benchmarks or goals do you hope to achieve within the next, 3 to 12 months?
Funding. Yeah. Funding. And then, like I said, the farm system's in place. So once we get the funding, I think we can be implemented and up and running and getting and have the pilot running in short stead. So, I'd love to get, if I can get funding within the next 2 to 3 months, then I feel like we can be in the early to mid part of our pilot by 12 months.
What kind of funding are you talking about? What does that look like?
So for a single site, the projections are we need about 600,000 to do the pilot. And part of that is, the cost will be less as we grow, but when you're in the early phases, it's largely all um, personnel. Person who's out there and boots on the ground has to have backup, right? I mean, so there's some replication that occurs that as we start to grow, we'll be able to consolidate a bit. But so it's going to be about 600,000 is what we need to get be fully funded in the pilot.
Okay. And what advice would you give anybody? Because I know you probably realize you can't do this all on your own. Worthy goals and mission, but if somebody wanted to follow in your footsteps and create a similar type nonprofit organization, what kind of advice would you give them?
Call me. Let's sit down over coffee and talk about um, you know how to move the ball forward. I think that would be critical. Number one. Number two, I think certainly, and I hope that, but I think everybody would benefit from us getting the pilot going and behind us, no matter how. So every the programs I built in my career, the teams I've coached in my career, I've tried to be prepared and I've tried to think through and solve any problem that might occur, right? However, with that being said, and you know this, you're always going to run into something you didn't anticipate. Something is going to happen that you did not anticipate, no matter how hard you tried, that you have to work through. And so it would be a lot easier for me to make all the mistakes, and then for those who wanted to replicate this elsewhere to learn from my mistakes and not have to go through them themselves, right?
Yeah.
And so, catch me and learn from me. Let me make all the mistakes. And then sit down and kind of go, okay, what worked, what didn't work, and what may have worked, but what you could have to make it work even better, right? And so that would be the biggest thing, I think. But if they really wanted to take it off on their own, I'm all for it. I'd be happy to help them and kind of tell them kind of how to get it off the ground.
No, I love where you're coming from with that. It's almost like the Roger Bannister story with the 4 minute mile, like proof of
Yeah,
concept to get everybody to believe, okay, this can be done. And
yeah,
that's great.
yeah, yeah.
So, you mentioned your website. Is there anywhere else that people could find you, Dr. J, if they'd like to get in touch and learn more?
Yes, yeah. So certainly the website, and there's a place on the website that you can click for, so you can directly email us from the website. Our emails are in the embedded in the website. So that is going to be the best way of finding us. But I'm happy to give you my email. It's kind of my old work email, but so it's not my, there's a BarryJarnagin at Pneumahealth.org email, but there's also BarryJ at tncph.org, which is the prior company I had. And people could certainly email me through that email as well.
Perfect. I'll make sure that information is in the show notes and description.
Yeah.
Well, Dr. J, it's been a great conversation. I really appreciate you being on again. Just want to wish you all the best and absolute success in everything that you're trying to accomplish here.
I have thoroughly enjoyed it, and I appreciate you having me and helping me get the word out. And, if you ever want to do this again, and I can tell you about my journey and or anything else you want to talk about. I'm also passionate in women's health. I'd be happy to discuss women's health, which is another area of medicine that is undertreated, particularly in the mature lady, if you will, the menopausal lady. There's a lot of need in that area as well, and only about 5 to 10% of menopausal women in the last study were getting the help that they needed and deserved. So there's a lot of issues out there that I'm passionate about. If you want to do it again, I'm happy to do it.
Yeah, absolutely. Would love to continue this discussion. Different topics would be great. So, yeah, that's great. I would like to also thank everyone for tuning in. This has been Jesse Garza with Premier Leadership Podcast. I've been speaking with Dr. BarryJarnagin, founder of Pneumahealth Ministries. If this has been helpful and insightful, please be sure to like, share, and subscribe. Definitely help us out to get the word out about the great things leaders like Dr. J are doing in the healthcare and business world. All right. I'll see you on the next episode.